Hi, I'm Peter Gloviczki from Mayo Clinic, Editor-in-Chief of the Journal of Vascular Surgery, Venous and Lymphatic Disorders. I am pleased to bring you 4 excellent papers of the May issue. You can download them this month free of charge. The first paper I would like to introduce to you is entitled Treatment Pattern of Consecutive Patients with Chronic Venous Disease, written by Dr. Joel Crawford and colleagues from Stony Brook University in New York. This is a retrospective review of 506 consecutive patients who visited the vein clinic of an academic medical center. 182 patients, 45.5%, had no saphenous reflux. 40% underwent treatment of superficial reflux, and of these 78% had ablation, and 22% had microphlebectomy or sclerotherapy. Most patients who needed treatment were in their 50s, but age ranged from 21 to 80. There were 1.7 ablations per patient, more in those with higher SEEP classes. Our take-home message from this paper is that almost half of the patients we evaluate at a vein clinic will not have saphenous reflux, and that the average ablations per patient is 1.7, higher in those with more advanced disease. But these data could very well serve as a benchmark to avoid over-treatment of patients with venous disease. The next paper I would like to introduce to you dealt with the important problem of assessing radiation exposure to our patients during endovascular treatment of chronic venous obstruction. This was written by Dr. Mohamed Esmail Barbati and colleagues from Aachen, Germany. In this prospective study, radiation exposure to 78 patients during endovenous recanalization procedures did not reach a level to have deterministic effects. Median operating time was 154 minutes. Median fluoroscopy time was 43.7 minutes. Direct measurements of the effective dose of radiation correlated well with indirect parameters of radiation exposure, like cumulative air kerma area product, and fluoroscopy time. BMI did not correlate with fluoroscopy time, nor with effective dose of radiation. In this study, there was no radiation-induced skin injury, and most importantly, no patient reached effective dose levels of deterministic effects. The authors warned, however, that radiation dose should still be minimized to obviate against longer-term possible stochastic effects of radiation. The next paper I would like to introduce to you is entitled Empirical Systemic Anticoagulation is Associated with Decreased Venous Thromboembolism in Critically Ill Influenza A, H1N1, and Acute Respiratory Distress Syndrome patients. This was written by Dr. Andrea Obi and colleagues from the University of Michigan in Ann Arbor. In this retrospective study of 70 patients with ARDS, 31 had H1N1 viral pneumonia. This group had a 23-fold higher risk of pulmonary embolism and then 18 times higher risk of venous thromboembolism and a 33 times higher risk of venous thromboembolism than those who were on empiric systemic anticoagulation. Main predictors of venous thromboembolism included H1N1 infection, bacterial pneumonia, and vasopressor requirement, while the use of empiric anticoagulation provided significant protection without increasing bleeding complications. The editor's choice article, that's also our CME article this month, is on ultrasound-based topographic analysis of tributary vein connection with saphenous vein in patients with chronic venous insufficiency. This was authored by Dr. Yang-Chul Yun from Seoul, Korea. This study calls attention to the fact that blood normally flows from the superficial compartment of the tributary veins towards the saphenous veins and then to the deep veins. Venous reflux occurs when blood is drained from the deeper to the more superficial compartment. In this retrospective study of 41 limbs of 30 patients, duplex ultrasound showed that 82% of escape points from reflux in great saphenous vein to tributary veins were located below the knee, and a mean of 1.9 escape points were found per leg. Tributary vein near escape points were large and had mean diameters of 90% of the great saphenous vein. So these data suggest that patients having above-knee saphenous vein ablation should probably have below-knee tributary vein treatment to prevent residual venous shunting and recurrence of varicose veins. Now, these were 4 of the many excellent papers from the May issue of the JVSVL. To access these articles, please log on to www.jvsvenous.org. Send us great articles you would like to see published. We are here to serve our authors and, of course, our readers. See you next time for the highlights of the July issue of the JVS Venous and Lymphatic Disorders.